Good morning and praise the Lord, everyone. Through the Lord's mercies, we are not consumed because his compassions fail not. They are new every morning. Great is your faithfulness. The Lord is my portion. Therefore, I hope in him. I'm Minister Sherilyn Brown, and I want to thank each and every one of you who have joined us today. This is a live session through the Unified Churches of the Pentecostal Assemblies of the Apostolic Faith, an apostolic fellowship here in the city of Milwaukee. Our presiding bishop is the Honorable Bishop Thomas Melton, and we would like to call on him at this time to give us a welcome. Bishop Melton?
God bless you all. So glad to be here. Just wanted to welcome our doctors, Dr. Kency and Dr. Brown. We just appreciate them for being here to share with us. This is probably part two of the presentation that Dr. Brown started with us when the pandemic started. And so we're happy to have her here for an update and to share with us what she's seeing now at this present time. So we just want to thank the doctors for being here to bring us that update and to share with us their experiences. So thank you both for being here today. We really appreciate you. We need more information so we can make a better informed decision on whether we get vaccinated or not, and learn the other things we can do that this crisis might diminish. So thank you again, and Mr. Brown, let's get on with the show.
All right, sir. Thank you so much. We do understand that you will be leaving us shortly because you are attending a funeral, and our prayers will be with you and the bereaved family. So I'm just going to introduce our panelists today. I'm so very proud to have them joining us. Um, so we are joined by two distinguished emergency medicine professionals. And I would like to introduce Fred Earl Kency Jr., MD, FAAEM. He is a board certified emergency physician and a native of Jackson, Mississippi, who is passionate about men's health. He received his Bachelor of Science in Biology from Alcorn State University and his Doctorate of Medicine from the University of South Alabama College of Medicine in Mobile, Alabama. Dr. Kency proudly served in the United States Navy for 4 years and was deployed to Africa and Europe prior to his honorable discharge. He returned home to Jackson, Mississippi to complete his emergency medicine residency at the University of Mississippi Medical Center. He currently serves as a community emergency physician at Baptist Hospital in Jackson, Mississippi, and is an assistant professor of emergency medicine at the University of Mississippi Medical Center. He continues to serve the community as a leader in Alpha Phi Alpha Fraternity Incorporated, American College of Emergency Physicians, and the American Academy of Emergency Medicine. Also joining us, Kimberly Brown, MD, MPH, FAAEM, is a board certified emergency physician, international speaker, author, and media personality with a passion for health education and disease prevention. She has been featured on Untold Stories of the ER, WMC5, Local Memphis 24, Fox 13, MemphisHealth.com, Medical Economics, and numerous podcasts. Born and raised in Milwaukee, Wisconsin, she received her Bachelor's of Arts degree from Fisk University. She completed a Master of Public Health degree from the University of Florida and earned her Doctor of Medicine degree from Ross University School of Medicine. Dr. Brown was part of the inaugural graduating class of emergency medicine residents at the University of Tennessee Health Center, Science Center in Memphis, Tennessee. Dr. Brown works and lives in Memphis, where she is a community emergency physician for Baptist Memorial healthcare throughout the Mid-South. She holds leadership positions in several organizations, including Ross University Alumni Council, the Junior League of Memphis, Bluff City Medical Society, and the American Academy of Emergency Medicine. And in case you didn't know, Dr. Kimberly is my daughter, of whom I'm very proud. And so, just to let you know, this is a live session, a live talk with our emergency physicians this morning. And those of you who are viewing us on Facebook, we offer you the opportunity to post your questions for the doctors to respond directly to your concerns. And so I just want to start out with a question for both you, Dr. Brown and Dr. Kency. Tell us, what do these letters behind your name mean? Dr. Brown or Dr. Kency?
Sure, I'll take that. So the MD, of course, stands for medical doctor. For me, the MPH stands for the Master of Public Health degree that I got at the University of Florida. And then we both have FAAEM after our names, which just means that we are a fellow of the American Academy of Emergency Medicine, which is one of the largest organizations for emergency physicians in the United States and actually the world. So.
Oh, beautiful. So, again, very distinguished, very well credentialed, and very well representing the medical society for us today. Let's look at this question I wanted to start out this talk with. When it comes to COVID-19, what are you seeing in your respective emergency rooms today compared to this time last year? And what types of symptoms are people experiencing now with the Delta variant compared to the initial outbreak? And then the third part of this question would be what you are seeing in your emergency rooms compared to the rest of the country. Dr. Kency, can you?
Trying to get unmuted. Thank you for having me on. Let me first say, but the things that we are seeing this time actually are a little bit different than what we saw in COVID original, COVID alpha, COVID beta. When we initially had COVID back in March of last year, a lot of the patients came in with very vague symptoms. I used to have some patients would come in with GI upset. Sometimes they would come in with loss of smell and taste. They would come in with fever. Fever wasn't as big, I think, last year as it is this time. And the sheer number of people that were coming in at one time seems to be a little bit different as well. On this go around, we're still seeing GI upset, but we're seeing a lot more people, especially our older population, come in dehydrated because it's causing a lot more diarrheal illnesses than it did in the past. So I've admitted quite a few patients who come in not because they were having oxygen requirement issues or oxygen pulmonary toilet type of issues that required like ICU care, but just they needed fluids because they become so dehydrated from just, the generalized weakness and the fatigue, not wanting to actually get up and just go to the kitchen and get something to drink. Their fevers were so high that they just had body aches. They just felt so bad they didn't eat. So we've seen a lot of patients that have come in for those type of reasons. In addition to, we are still seeing plenty of patients that do come in respiratory distress, that are coming in because they have so much inflammation in their lungs. And these are the patients you usually see around day 7 or 8 of their illness. So we now can almost, chronicleize timeline when a patient will likely present to the emergency room because of COVID. You have those early patients, the ones who got that first cough, that first sniffle, that first fever. They're coming because they want to know if they have COVID. And those are usually the well patients we have. Their temperature may be elevated, but their O2 sats are fine. Their lungs are clear. If you did a chest x-ray, which we don't typically do on patients who just started symptoms, they're usually completely normal. But These are people who just started having symptoms, so they're coming to the ER to get tested, which we recommend they go to their primary care doctor or to some of the state sites that do testing in their vehicles where they don't have to actually get out and expose themselves or expose other people. But if you come to the emergency room, obviously you will be treated. So those are our kind of what we call the walking wounded in the military. The other population we see are the patients who come back at around day 8 to 11. And that's kind of that time frame of when patients typically start to decline if they are going to decline. And so we have that day 1 or 2, and then we have the day 8 to 11. Usually in that middle time, we don't see many of the COVID patients, unless they're more the dehydration type of people, like around day 5. They got their symptoms on day 1. They started feeling real bad. They stopped eating and drinking around day 2 or 3. And now they're just so tired. They're just so dehydrated that they're coming in more for the fluids and such. But that kind of day 8 to 11 are where we're seeing the very ill patients, the patients that come in who are satting in the 70s, who are satting in the 60s, who have complete respiratory distress, ones that are sometimes requiring intubation to be put on a ventilator immediately upon presentation because they're doing so poorly. And it's amazing how fast it happens. I've talked to so many families where they'll say, John was doing great yesterday. Like, we thought that he was turning around. We thought that he would be back at work. If today is a Saturday, we thought he'd be back at work on Monday because he looked so good. Right. And then it's just like, boom. They wake up that next day and it just hits them so hard that they're barely able to get from their bathroom to the kitchen, from the kitchen back to the bedroom because they're so short of breath. And those are the ones, obviously, they're going to require a lot of work to get them turned around. And that part of it is still very typical of what we saw initially. That time frame is still very, very typical. It is the same time frame we saw a year ago. That day 8 or 9, 10, 11 is where it's kind of decisions are made. If you get to day 11 and you're not, struggling to get from your bed to your bathroom to your kitchen back to your bedroom, you are usually going to be okay. Some patients are still going to have fatigue. Some people are still going to have some fevers. But if you're not admitted to a hospital by day 11 or 12 after you started your symptoms, it is unlikely that you'll likely need any further intervention.
Yes. Dr. Brown, do you have anything you could add to that?
Sure. I'd like to just echo what Dr. Kency said. I'm seeing a lot more patients coming in at that day 8 to 11, 12 period of time, and they're very short of breath. They just can't breathe. I've had several patients come in recently, though, that have chronic medical problems that came in for shortness of breath way earlier and had COVID pneumonia much earlier. And when I say earlier, I mean probably having symptoms. Let's say day 1 is symptoms. Day 3 would get the diagnosis. By day 5 or 6, sometimes they're back in the emergency department, short of breath. Oxygen saturations are very low, requiring higher and higher levels of oxygen and needing to be admitted as well. I would say the positive thing, or some of the positive things that I see now versus at the beginning of the pandemic, is that we have so many more tools at our hands to try to combat this. When I was first seeing patients back in March, April with COVID-19, it was really kind of give antibiotics and know that this is likely a virus and wait for a COVID-19 test to take about 4 to 5 days to come back. And the patient is upstairs admitted in isolation until that comes back. And we were just having to go off of lab work to try to guesstimate, is this COVID or is this not? But now we have all kinds of treatments that have been used to help patients that if they do get sick and they do come in the hospital, then we can have that to treat them, that meaning steroids. If you're coming in the hospital and you need to be on oxygen, a lot of times you will get dexamethasone, which is a steroid. There is an antiviral medicine called remdesivir that you may be eligible to get if you're in the hospital. And then also, too, there is a therapeutic that we have that hopefully will prevent you from getting into the hospital if you do have COVID, And that's the monoclonal antibodies that is an infusion therapy, or sometimes they can just inject it under your skin like an insulin shot. It depends on where you are, but those have been shown to at least decrease hospitalization in patients with COVID-19. So as a doctor, I feel as though I have more things that I can possibly offer to patients, because even a few months ago, I'm just like, I don't know, this is COVID. This is how you feel. You got to try to just stick it out and then monitor yourself at home. If things get worse, of course, come back, and then we have some options for you, which is part of the talk that I gave earlier a few months ago, is that, I just kind of told them maybe this, and if you come in the hospital, I do have these tools, but I do have more as an outpatient treatment, especially with the monoclonal antibodies becoming more widely available to patients. And so that's been very helpful in trying to at least decrease the flood of hospitalized patients in our area.
Okay, let's kind of break that down. What is that? I can't even say it.
Sure. Monoclonal antibodies.
Okay.
So just to break it down, not you guys know I don't like to get too sciencey, but when your body it mounts an immune response, it forms all kinds of antibodies. It will, let's just say they call them A, B, C, and D. What we will do is, or what monoclonal antibodies are, is they will isolate one specific type of antibody. Let's just say it's B, and pull it from different people. And that they have found that those B antibodies are targeted exactly to treat, let's say, COVID-19. So what monoclonal antibodies are is that people who have recovered from COVID, we have drawn their blood, filtered out the plasma, filtered out the antibodies directed directly against COVID-19. We are pooling those, cleaning them, making sure there's no other infections like HIV, hepatitis, things like that, and also administering to patients who have COVID-19 so that their bodies will know how to fight the virus as well. So those are specific antibodies that are targeted towards COVID-19 so that your body will be able to fight it off. Just like if you got the vaccine, if you'd have natural antibodies towards, or had been had COVID-19 in the past, have natural antibodies to COVID-19, you would be able to do the same thing, just to go ahead and produce antibodies to fight that virus.
Since you mentioned the vaccine, that's a good segue, because part of this conversation we're having, we already know that there are people who are resistant, hesitant, not vaccinated, don't want to get vaccinated, thinking about getting vaccinated. Let's kind of demystify the vaccine for some people who may be sitting on that fence. Can you kind of explain to us so that people would understand and be more willing to become vaccinated? Why get a vaccine? Why do we want them to become vaccinated?
Definitely. I tell it like I tell my patients who come into the ER all the time. At any given time in our emergency room, at least in the last 2 months during the Delta surge, we've had at least 100 patients admitted to the hospital at any one time, at least 100 patients. In my state, we've been about somewhere near the 40% rate of vaccination for the state. So 40% of our population of our entire state has the vaccine, 60% doesn't. At any given time, we've never had more than 3% vaccinated people in our hospital admitted. So that tells you that never in 3 months have we had more than 3 people out of 100 admitted to the hospital because of COVID who were vaccinated. Never. The vaccination works. It keeps people. It may not, and there's always this high misconception that you got the vaccine, but you still got COVID. Yes. The vaccine we've only had one vaccine in entire history that has eradicated something, and that was smallpox. It was great. It was a medical amazing thing that happened. I'm very happy that it happened, because if anyone has ever done any research on smallpox, the way it disfigured people, the way that it caused death, the way that it caused illness was horrific. And I am very happy that we do not have that virus in our system, in our world anymore. But vaccines were not made to completely eradicate. They were made so that when your body was exposed to this, specifically COVID, that you would have a pre-planned identification of what you needed to fight. Your body, as soon as you walk, it's just like putting out a bolo for police, is that we're on the lookout for this person. He's driving 3 spikes in a protein. They're colored like this and they look like this. If you see him, you let everybody know we coming to get him. That is what your body, that is what a vaccine does.
Okay.
It puts out a bolo to your immune system that says if this guy is spotted in your body, tell everybody so we can send backup and we can try our best to destroy him as fast as possible. Because when a virus gets in our body, their job is to invade cells and to replicate. And when they replicate, they destroy cells, okay? So your body needs to know what this looks like as soon as possible. If you are not vaccinated, that means that you are giving the virus more time to replicate in your body because your body does not recognize this virus. I don't care how much kale you eat. I don't care how much ginseng you take or how much elderberry you drink or how much vitamin C you take. If your body does not recognize what it's being infected with, you cannot fight it. It does not matter how healthy you think you eat. It doesn't matter how many times you do yoga. It does not matter how skinny you are. I have written death certificates for the skinniest people I've ever seen. Wow. It does not matter. Those things, I know people, they love to say, but I'm going to focus on my immune system. Your immune system will do so much better if it knows how to fight and what it's looking to fight, okay? If you want to help your immune system, get vaccinated.
That's a good point. Can you put the question back up from Pastor Price, please? She says, if you already had COVID, please explain why the antibodies are not enough to prevent you from getting sick again or dying. And some feel that they don't need to be vaccinated. Okay, can you address that?
Definitely. We've had this one multiple times. What happens is most people's immune response to COVID, it varies. You have anything from someone who loses their taste and never has a single pulmonary system, never has a single body ache, never has a single fever, all the way to complete respiratory failure and death, okay? What the type of immune response you produce is directly related, and we know this because of testing. The kind of immune response you produce is directly related to how sick a person gets from their COVID. So we know that a person who has very mild symptoms, I had a fever for a day, I had sniffles for a day, I lost my taste for 2 days. Those people are less likely to generate a significant immune response, which means that though you had COVID, your body did not learn the virus as well as it could have, because likely you were not inoculated with enough of the viral particles for your body to truly mount that response. It's kind of like saying, if we were talking about war, you had one Russian that came and invaded your land. Well, one person saw him and one person shot him. So now you won the war of that one person coming to get you, but nobody else knows what he looked like. Only the one person that saw him did that. But if you get an immunization and you spray thousands of those people across the United States, now we have a huge collection of people who have seen this problem, who have seen these spike proteins, and next time we're able to deal with it more effectively. So having COVID, though you may have some immunity, there's no standard. I know that if I give you the immunization, it's standardized. We know that because we had testing between Pfizer and Moderna of over 40,000 people in each case study. And we know that those injections produce this much immunity. So it's standardized. I can tell you that if you get this vaccine, the chances of you getting COVID is this much, and then this much, and then this much, based on these dates and these times, because it's standardized. If you get COVID yourself, and depending on your symptom level, there's no standardization. So you may have almost no immunity. I've had people who had COVID, very mild symptoms. They went to get their antibodies checked. They were initially positive, but they went to get them rechecked in 2 or 3 months, and they had completely gone. They were gone. They didn't have any immunity anymore. Wow. Because it was such a small inoculation that their body didn't get a chance to mount a good response.
So when I add something to that, okay. Mr. Brown, just like Dr. Kency is saying that I think part of the reason too why we are seeing people get reinfected is that because there is a large amount of virus that is circulating in the world. I'm not even going to say in the country. I'm just going to say, go ahead and say the world right now. Every time a virus or the COVID-19 virus passes on to somebody else, that gives it a chance to morph into becoming smarter, evading the immune system, to evading the vaccines if it continues to replicate. And so part of the reason why we're seeing people getting infected again is because the virus itself just has gotten smarter. And it's able to kind of morph and move around the natural antibodies that you may have produced if you've had COVID. And in some patients, very, very few though, it may invade the immune system, even if you have been vaccinated as well. So it's a multi-pronged problem. And it's really important, though, that still people are vaccinated because, like Dr. Earl is, I'm sorry, I keep calling him by his middle name, Dr. Kency is saying, is that the likelihood that you would get infected is still drastically low. And in the hospital is even lower with COVID-19, and dying from COVID is pretty much 0%.
Okay, and let me interject this right now, please. For those of you who are watching live, I do want to encourage you to like and share this video and to post your questions online so that Doctors Kency and Brown can address any questions or concerns that you may have regarding COVID-19, the variants, and the vaccine. I have a question that that was given to me about the individuals who describe themselves as having, the ability to resist COVID. Is that true? Is there anybody that walks this earth that has the capacity to resist being infected by COVID? And what do you say about that?
100%, like never ever, not even like there's no possible way that they would ever get infected with COVID-19. Is that what that person is saying?
That's what they're saying, yes.
Okay. I'm going to go ahead and say that's false. Unfortunately. That's false. Even though we have vaccines which are safe and proven effective against people getting COVID-19, and if you did get COVID, the chances that you were, like I just said, hospitalized or die from COVID are extraordinarily low. There is nothing that we have done as a healthcare field that we have discovered is 100%. Of course, we have prayer, we have fasting, we have, blessed oil. But just like Dr. Kency said, there is not one thing that is going to say that you would never, ever get COVID-19. We do have lots of other measures that have nothing to do with medications that have been proven to be effective against COVID, that being wearing a mask is still effective of you not getting COVID-19. Social distancing, 6 feet of space, and washing your hands regularly, and not gathering in large crowds. Those are still effective ways for people not to get COVID-19. But I hesitate to say that there is a person on the face of the planet that cannot be touched by this terrible virus. it's just a little bit too cavalier to say. And at the end of the day, God holds it all, but he's also been able to give us these tools to fight the virus. I wouldn't just be so cavalier to say that there is one person somewhere that is 100% immune to this virus.
Absolutely. The question is now, are boosters necessary? And let me interject this before you respond to if boosters are necessary. I know of individuals who had COVID and now feel safe. They, in their own mind, feel safe that they will not get COVID again. So they refuse to take the vaccine. So is that say some erroneous thinking on their part?
Very, 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 very much. And it is just like saying, if I get the vaccine, I won't get COVID. There's nothing that's 100%. Getting the virus does not make you immune to getting the virus again. And like I mentioned earlier, statistically, we don't know what protection you getting the virus one time even gives you. We know how much a vaccine statistically gives you based on time because we are still following the subjects from the original studies. So we know that at 14 days after your second shot of Pfizer or Moderna, you have a 94% chance of not getting COVID. You have almost 100% chance of not getting severe COVID, meaning the one that puts you on the high flow machines or puts you on the ventilator inside of a hospital. I can statistically tell you that if you get the vaccination, your chance of ending up in a hospital and dying from COVID are pretty low. I mean, statistically, they are very, very, very low. But you can't say the same for a person who lost their taste for 2 days and tested positive for COVID and felt better on day 3 and never had another symptom. Like, we just don't have the data that says that you are protected.
Okay, good response. Thank you. So do you say that it's necessary to get booster shots? Because we know mandates are coming down from employers for their employees to be vaccinated. Some of them have already passed the deadlines that they gave their employees, and they're still not getting vaccinated. And those who were vaccinated, should they be expected to get a booster shot?
Well, the data right now is...
I'm sorry.
I'll take it.
Okay.
So the data right now is showing that probably for healthy people within the first 8 months, your immunity starts to wane against COVID-19. So that's important for professionals like Dr. Kency and myself, who were both vaccinated quite early because we were in the first group to be, offered the vaccine, and we were eligible to take the vaccine then. However, what we are seeing too is that a lot of the patients who have been vaccinated and are still having breakthrough infections are usually older patients. So we're seeing like the 60 and up crowd, unfortunately. And what we're finding now is that their immune response has waned a little bit quicker than a standard, healthier, younger patient. So there's likely going to be vaccines for people who are older. And right now, the CDC is recommending that patients who are immunocompromised go ahead and get booster shots. And let me explain what that means. Mm-hmm. Immunocompromised is someone that has their immune system already suppressed or not working at its full capacity for some reason, whether they have HIV, AIDS that's been, full blown, from HIV to AIDS. You have patients who have cancer who are undergoing immune therapy to lower their immune system to fight off cancer. A lot of times people that take steroids on a regular basis, so whether they have chronic asthma, chronic lung disease, other disease states that they need to take steroids all the time, such as prednisone or dexamethasone, et cetera, so forth, they may be at a higher likelihood to show a diminished response to COVID-19 after a longer period of time. So the CDC is recommending that they will need booster shots now. So if you've fallen in that category, meaning if you've already had 2 doses of mRNA vaccine, which is either the Pfizer or the Moderna shot, then you are likely eligible now to get a booster shot. Those of us who are otherwise pretty healthy and no other medical problems, we're still waiting on the CDC guidance and also the data to come out from Pfizer and from Moderna about the booster shots. But we also need just a reminder. A booster shot is just a reminder to your body, like, hey, you remember this? Do you still remember how to fight it? If not, here it is again. Let me expose it to you so that you can remember. Just like what Dr. Kency was saying is that, you know what, that Russians coming through the enemy lines again. Remember, y'all remember how to shoot that person down? Go ahead and get that spike protein down, and making sure that your immune system remembers how to fight off the COVID-19 virus.
Okay. Dr. Kency, you were going to say something regarding?
Yeah, the FDA just released information recently that it is very likely that they're going to give the Pfizer vaccine takers the authority to get boosters regardless of your past medical history sometime next week. So I would be looking for it to come down. For Moderna, it's not so clear. It looks like they're probably not going to they're not going to grant them booster authority right now because and this is all based on data, which is amazing, which is great. This is what we want. So we know based on those prior research participants that people who took the Moderna, their antibody levels are actually still much higher than people who took the Pfizer. So because of that, there's a benchmark that the FDA sets for a person to need a booster. It says that your antibody levels have to drop below a certain percentile at a certain time to qualify for you to get a booster to try to take it back up to a higher level of immunity.
So can I ask you this? I'm sorry to interrupt you, but is there a way to measure the level of one's antibodies of individuals who are already vaccinated?
Yes, ma'am. We have ways of measuring antibody levels.
It's just a simple blood test.
Mm-hmm.
Okay.
And you can get it. A lot of people can have these tests done. They're not as easy to interpret because of the way they come out. They come out in these ratios. So like 1:8, 1:16, 1:256. So it's not as simple to interpret, but it can tell you if the antibodies are present. And so you can get a yes or no. It's easy to say yes or no. It's hard to say how good are they. Okay. And that's the part that is troubling when it comes to people who have had COVID, because they see, yes, for the antibodies, yes, you do have them, but do you have enough to actually do the job that's needed to suppress the virus? And the reason we care about immunocompromise, as Dr. Brown mentioned, is that remember that the more antibodies that we can produce, the more we have, the faster we can neutralize the virus once it gets inside of our body, okay? The virus enters our body. The antibody literally goes to that virus before it gets into our cells, and it sticks to that virus. Once that antibody is stuck to that virus, it's neutralized. It cannot enter your cell. It cannot do anything. Eventually, it will just wither away and it will die, okay? People who are immunocompromised, their immune systems are less likely to produce an overwhelming amount of antibodies, okay? And that's for any reason, whether you've had chemotherapy, whether you have HIV and you just don't have a lot of T cells and lymphocytes to produce these antibodies. For whatever reason, if you're immunocompromised, you just don't have the opportunity to produce as many. And so those people are just more likely to have the virus enter their body and just run amok because they don't have those neutralizing antibodies to do the job. And that's where, as Dr. Brown mentioned earlier, the monoclonal antibodies and the convalescent plasma come into play. We have these two modalities now, the convalescent plasma, which is people who have had COVID before, and we clean their blood, we clean their plasma, we take those antibodies and we give them to someone else, or the monoclonal antibodies, which is essentially we took that antibody that was naturally produced and we genetically copied it and made billions of copies. And now we can actually inject that into people and it can do the same job as if your body had produced those antibodies itself.
Phenomenal. medicine is so phenomenal, and we know it's God's design for us to know. I have a question that specific to gender. Is there any equity or inequity in terms of how the vaccine works between men and women? Are men more likely to be more better reactive to the vaccine than women, or along those lines? Can either of you respond to that question?
If you look at the data from the Pfizer and the Moderna studies, they were very balanced. So it was 40,000 people in the study for Moderna, 40,000 in the study for Pfizer. There were pretty equal male to female ratio. It was 20,000 and 20,000. And then of the vaccine takers, so you take 40,000 people, that's the number of people in the study. You take half got the half got the vaccine, half did not get the vaccine. They got what we call a placebo. And so they all got an injection, but the person did not know if they were getting the actual vaccine or just some salt water. Okay. And so of that 40,000 people, 20,000 got the actual vaccine. Of that 20,000, half were male, half were female. When the data came out, it was consistent that no more female than males got COVID. So it's fairly balanced.
Okay.
That's on Moderna and Pfizer. I can't say for Johnson & Johnson. I didn't read their study as well.
Okay, we had two questions before Lisa, but let's address this. Which population of people are more resistant to getting the vaccine?
I don't even know if it's a real population. I mean, honestly, it is everyone you can think. I'm in the South. Okay, I'm in Mississippi. So in Mississippi, I can tell you that my African American patients are resistant. My young African American patients, my old African American patients, my Republican patients are very resistant, and they're more resistant to the idea of the choice, not the actual vaccine itself. It's more, it is my choice to do this, and you should not be forcing me to do it. Whereas my African American population are just like, I don't want it. I just don't want it. Mm-hmm. And they can't really, give you an articulate reason as to why they don't want it. They just don't want it. And if they attempt to give me an answer as to, one of the early answers was it was developed too fast. And then when I educate them on the idea that, well, what if I tell you that mRNA vaccine technology has been around since 1998? What if I tell you that a Russian came over, gave us this information in 1998 in an attempt to create a vaccine against HIV? What if I tell you that we've been looking at this technology for 23 years? Does that make you feel better about the time it took to develop it? No.
But that's the attitude. They think it takes another 10, 20, 30 years before we will have a solution for this.
But you know what? But then you know what? That was what we were facing until we started applying the mRNA technology to COVID-19 and found out that it worked. And honestly, there was a lot of federal money, government money that was poured into the health development and research community so that we could quickly develop this. There was a lot of money in order to remove red tape, to hire more people to review standards and to review things to make sure that it's safer. So things moved quicker because we had done the research, like Dr. Kency said, early enough. We applied it to this problem. It worked. And then money helped to rush things along, meaning getting things, not that any steps were skipped, but making sure that the steps that are in place, there were more people to do those jobs to make sure that it was safe and effective so that it could get out on the market. I was one of those ones that were saying at the beginning of the pandemic, oh, child, please, we're not about to see a vaccine until about 2024. We're going to be in this world for a long period of time. But thank God that there has been someone that was researching mRNA vaccines, and it applied to this problem and it works. Thank the Lord. It's honestly a medical miracle that we had something in our toolkit that we didn't know that was going to work, but thank God that it did. How many lives around the world, how are we saving right now because people are getting vaccine and getting the mRNA vaccine?
Yes, absolutely. We do thank God. Do you suggest we should increase our public PPE again since different variants are rising?
I will go ahead and take that. So I live here and our city mayor just reinstituted a mask mandate for the city of Memphis a couple of weeks ago, because we are seeing our numbers increasing and off our masks, and people were on the honor as far as if they were taking off their mask, if they were vaccinated or what have you. Still the numbers have been circulating. And like I said earlier, we do know that masks are effective at preventing COVID-19, at least a prevention standpoint. I think we're right now as a society focusing a lot on treatment, but it's still very important to try to prevent yourself from even getting the virus in the first place. Vaccines are a way to prevent you from getting COVID. But for a long time, we were able to see that masking, hand washing, and social distancing were effective, and they still are. All of the research still shows that all of those things still work against preventing COVID-19. So even, and this is a personal decision, of course, even if vaccinated, if you're going out in public spaces, especially like the grocery store, social setting,
Dr. Brown,
now that the CDC is recommending it as well.
Mm-hmm. Unfortunately, we didn't hear everything, but you're breaking up pretty much there. But I'm pretty sure that we could grasp what you were saying. But if Pfizer, the question is, but if Pfizer was advertised as having a higher efficacy rate, why does Moderna have a longer span before the booster is required? I took the Pfizer. I was encouraged to have Pfizer, thinking that it was going to be better.
Yeah. And so when the initial data came out, it was a 6 month, if I remember correctly, it was a 6 month antibody or sickness data that came out. It said, and if I remember correctly, it wasn't that big of a difference. It was like 96% versus like 94%. It was pretty close. J&J was obviously a lot less. It was down in the 70s, but the percentages were pretty close. And we don't have a great reason as to why one type of vaccine lasts longer than another type. You know, it's hypothesized, and I was reading a study earlier, actually yesterday. It's hypothesized just because of the type of the way the proteins are wrapped when they're injected. So the idea is that the Pfizer, one of them essentially has a lipid covering. One of them has a sugar covering. And the idea is that because of the covering, it just changes how the body will absorb and then mount its response. But
so
we don't
lipid versus
sugar.
Lipid, right? So fat versus sugar covering.
Sugar. That's the easiest way to say it.
Okay.
One's covered in fat, one's covered in sugar. And we inject that in the body. It's pretty much the spike protein, what they look like are fairly identical for Moderna and Pfizer, but the way their delivery systems are developed, which is what made the difference in their two technologies. And J&J is completely different. So Johnson & Johnson, where we took, so for the Moderna and the Pfizer, we literally took the core proteins, we made copies of them. So it's not a true viral particle. It's just pretty much a skeleton of what the virus looks like so that you're able to identify it. It's like making a mannequin and saying, this is exactly what the virus looks like. It's not real. It's not going to harm you, but this mannequin is exactly what it looks like. So if you ever see it, you get them. Okay. That's Moderna and that's Pfizer, and that's wrapped in a fat or wrapped in sugar. Okay. Johnson and Johnson.
So let's segue just for just a moment to something else. Because school is back in session now, what are we seeing? And I know already here in Milwaukee, schools are closing because there's an outbreak of COVID. But What can you give us in terms of information about our children and the vaccine and COVID, or encouragement to get the vaccine for our children?
So right now, the vaccine is only allowed for children 12 and up. So we're still limited in even which children can get the vaccination. Luckily, and it's all prayer and hopes and luck, right now we have not seen a huge number of children to succumb from the virus. Okay, that's just all luck, and I'm very happy that we have not, because there's nothing worse than the death of a child. But we are still seeing some pretty bad outcomes from children who have gotten COVID. Either the long outcomes of some almost asthma type of presentations, where they're having some respiratory issues for prolonged periods of time. We've had children that have had some kidney dysfunction for some prolonged periods of time. And we've had some kids with some weird skin manifestations for some prolonged periods of time. But if you look at the sheer number of children who have tested positive, unvaccinated, to the number who have these kind of long-term pathologies, the numbers are still low. Okay. So that is very reassuring that if your child gets COVID, the chances of them having a poor outcome is very, very, very low. The issue is when your child gets COVID, then who do they come in contact with? The child is the one who gives it to grandmama, or who gives it to uncle, who gives it to the older cousins. And those are the ones who have the high risks of having poor outcomes. So right now, luckily, prayerfully, the children are faring fairly well. Here in Mississippi, since COVID began, we have had, I think as of yesterday, 6 pediatric deaths, and they count those as 17 and below. So we've had 6 in 19 months. So, statistically, death is never good, but statistically, that is actually not terrible for the number of people in that age group that have tested positive.
Yes, sir. We have less than 5 minutes. This has been so informative and very rich. And so, Dr. Brown, could you basically kind of summarize for us some things about COVID-19, the variants and the vaccines, and in our closing of this conversation today?
Sure. Thank you to the Unified Churches and Minister Brown for having both of us. First of all, it's really important, I think, right now as we're going into our fall and winter months, especially as things are getting colder up there, not down here. It's still like 80 degrees down here, but up in Wisconsin and wherever people are watching from, things are getting colder. That means that we're moving indoors, and the likelihood that we're going to see possibly another spike of the virus is looming ahead of us in the emergency departments and on the front lines of this whole pandemic. I think that it's very easy to feel as though this is a hoax, because this is not what people see every day. If you're not working in healthcare, if you don't know someone that works in healthcare and are treating patients with COVID-19, it's very easy to believe that it's not something as serious as it is. Dr. Kency said a few things that for the general public, I don't think that they fully understand. Meaning, as far as he was saying, there's about on average 100 patients in his hospital with COVID-19 since the beginning of the pandemic, or in the last several months, he says. That is unprecedented. At no point in time does anybody, 100 people come in the hospital thing ever, and that will drain our resources regardless. So there's a lot that's going on, and it's also affecting other people that don't even have COVID-19, because now that I have 100 people that are taking up all this care, that I am not able to treat the simple appendicitis. I am not able to treat the simple heart attacks, the strokes, things like that, because I don't have the space for that. So a lot of times vaccination, or I would say this, vaccination is not necessarily for ourselves. It is for the general public. It is for for the children who are 12 and under who cannot get vaccinated. It's for a grandmother who's 85 plus, who may have vaccinated, but still is at risk because she's 85. So it's more about thinking about ourselves as a community, as a body of Christ, as one unit, and trying to making sure that everybody else is okay. Once we put on our own oxygen mask, then you have to help somebody else. So I would just say, if there's any other questions or concerns about what's going on with the Delta variant, we're seeing other variants coming across the horizons every day now, because things are just going so crazy right now with this pandemic. To just go ahead and ask questions that you're having. There's so much information that is on the internet. I would encourage you, even though we're doing a Facebook Live, and I'm glad that you got us as credible professionals, but to go on FDA's website, to go on the CDC's website, to go on Pfizer's website, Moderna's website. They have so much information from the people who are actually putting this product out there. And you need to know the correct information to make sure that you're getting your information from the correct sources. And of course, all of the,
of course,
experts on the planet, to make sure that we are able to give information to people who want it, and to make sure that we're saving lives in any way possible.
Thank you so much. I know part of your last comment was broken off because of the interference with the technology, but I do want to say thank you on behalf of the Unified Churches of the Pentecostal Assemblies of the Apostolic Faith and our presider, Bishop Thomas Melton, and you joining us today and sharing the plethora of experience and knowledge that you have as emergency medicine physicians, working in Dr. Brown, Memphis, Tennessee, and Dr. Kency, Jackson, Mississippi. Thank you for your time. Thank you for your studies, and thank you for your knowledge. And we pray for you and all those who are working on the front lines in a continued effort of making sure that our community as a whole is healthy and safe. And on that note, God bless you all who are watching, and keep us in your prayers as well. And thank you again for joining us for another conversation about COVID-19, the variants, and the vaccines. Be blessed, everyone.
Thank you.